Good morning, sir. Good morning to everyone. And today we'll be continuing with our discussion on sarcopenia. And today we'll be discussing about sarcopenia and NAFLD. We have already discussed most of the aspect related to sarcopenia and cirrhosis or its complication. So why we have to discuss sarcopenia, especially in NAFLD, or what is the interplay between liver and muscle? That skeletal muscle is a crucial endocrine organ that mediates the crosstalk between the adipose tissue and the liver. It is also an essential role in energy metabolism and skeletal muscle alteration involved in the pathogenesis of NAFLD. That is what we will be trying to discuss. So the overview would be to discuss the burden of disease, especially NAFLD and sarcopenia, the pathogenesis and the treatment options that are available. To study, there are few meta-analyses which show that sarcopenia is prevalent in NAFLD. This meta-analysis of 4 studies with more than 3,000 patients published in BMC Castro. It said that there is an association of sarcopenia with steatohepatitis, and it is increased by around 2.3 times. Even sarcopenia is associated with advanced fibrosis. Another meta-analysis of 6 studies with 19,000 odd patients. It said that sarcopenia and NAFLD, they are associated with increased odd ratio of 1.3, and there is also risk of progression of NAFLD in patients who have a baseline sarcopenia. Another meta-analysis of 19 studies published in 2020, it said that those patients with the skeletal muscle mass index, which is less in NAFLD as compared to healthy controls, they have around 1.7 times lower SMI in NAFLD as compared to healthy controls. Then there are few population-based studies. Many of the evidence of the population study, they come from the Eastern countries. Like the Korean study, which is a cross-sectional, NAFLD was assessed based on the CT imaging, sarcopenia by DEXA. It says that there is a 5-fold increase of NAFLD in these patients. Another cross-sectional study, it said that NAFLD and sarcopenia are associated with, there is an increased risk of sarcopenia in NAFLD patient by around 3 times. There is also increase in fibrosis in patients with sarcopenia. One study from Korea of 309 patients where the NAFLD was assessed by histology and sarcopenia assessed based on the bioimpedance analysis. It said that there is a 2.5 times increased risk of NASH and significant fibrosis. One retrospective study from America where the NAFLD was assessed based on the biopsy and sarcopenia by CT imaging. It said that there is an increased risk of NASH and NASH cirrhosis in these patients. And few other studies from Italy and America also suggest that there is an increased risk of NAFLD and sarcopenia. And the prevalence of the advanced fibrosis, it increases, the sarcopenia increases, or the prevalence of sarcopenia increases with the progression of NAFLD. It is even present if there is no fibrosis, increases in patients who have minimal fibrosis to advanced fibrosis. We may say that there are limitations with this population-based study that the assessment of muscle mass and liver fat, they vary. There are very few histological-based studies, and there is an ethnic variability that most of the evidence they are from either China or Korea. Another study from the Korean population where 7 years cohort study of 10,530 patients who didn't have baseline NAFLD with 2,631 patients with baseline NAFLD. NAFLD was defined based on the hepatic steatotic index of more than 36 and skeletal muscle mass index based on BIA. It said that those patients who had a higher tertile of baseline SMI or the skeletal muscle mass index, they have a lower risk of development of NAFLD on follow-up as compared to those who had a lower baseline skeletal mass index. They had a higher prevalence of getting higher chances of or incidence of having NAFLD in follow-up. They also found that the baseline SMI also, if there is a baseline SMI which is high, these patients will have more chances of resolution of NAFLD. And also if the skeletal muscle SMI is high, there is with an increase in time, like they studied that after 1 year, if the SMI increases, even then there is a chance of a significantly higher chance of resolution of NAFLD in these patients. Then even the NASH has been seen to have association with sarcopenia, where a retrospective analysis of 207 cirrhotic patients, all these patients they underwent liver transplant, and the CT was done 3 to 6 months prior to patients undergoing transplant. This was not, they had mixed etiology, but NASH was seen in up to 22% of these patients. in this study, they found that nearly 59% of the patients had baseline sarcopenia, and they found that NASH was associated with 6-fold increased risk of having sarcopenic obesity in cirrhotic patient. Also, it is not just the baseline NASH, but also severity of NASH, which is associated with severity of NASH is also associated with the progression as well as with the substitution of adipose tissue in the skeletal muscle. In this study, where 208 patients who had biopsy-proven NASH or NAFLD and CT-based estimation of the intramuscular adipose tissue content, they found that the factors which were associated with severity of NAFLD, that is, the patient who had a biopsy of simple steatosis compared to NASH, the IMAC was significantly associated, and also the HOMA IR score. Also, the factor which was associated with the severity of NASH was also seen that the intramuscular adipose tissue content was significantly associated. So what is the key mechanism that actually interplay between the skeletal muscle and liver? We have already discussed in detail about the myokines and hepatokines, but the other factors that we need to understand is the anabolic resistance. There is a systemic as well as local insulin resistance and systemic inflammation, which are key for the progression as well as for the progression of NAFLD as well as for sarcopenia. So what is anabolic resistance? That with age, as we have previously studied, that sarcopenia is an age-related phenomena. So with increasing age, there will be inadequate muscle protein synthesis, inadequate stimulation, and inadequate amino acid availability. Along with this, if there is a systemic inflammation or insulin resistance, that all leads to anabolic resistance. So how do we actually overcome anabolic resistance? Is it just by doing exercise or providing amino acid? We will discuss about the treatment aspect in detail, but one study that I wanted to discuss was the improvement of the non-invasive NAFLD in patients who underwent a web-based exercise program. All these patients, 44 patients, they were biopsy-proven NAFLD, and they were individualized for exercise for 8 weeks. What they found that not only the peak oxygen available oxygen and during exertion increased by 12.2%, also the liver parameters like AST/ALT decreased significantly. There was decrease in the inflammatory markers like HSCRP, ferritin, and M30. Decrease in the non-invasive markers like FLI, FIB4, and transient elastography, and the ProC3, which is a precursor of the collagen 3, also decreased. Then insulin resistance also is seen to have a major role in the progression of NAFLD as well as sarcopenia, where the adipose tissue macrophage infiltration triggers a local inflammatory state leading to insulin resistance, and this increases the lipolysis, inhibits the IGF-1 signaling. The association of NAFLD, NASH or insulin resistance was well proven, and this study, one of the first studies in 2002 published in Hepatology, where patients of NASH cirrhosis, 19 patients who were biopsy proven, they were given 150 grams of glucose, and they underwent a frequency sampled IGT test. And what they found that these patients, especially the patients who had NASH in comparison to controls, they had lower insulin sensitivity. They had higher basal sensitive response for insulin secretion, but the overall utilization of insulin was same in NASH and control patients. That is, the insulin resistance is more frequent in NASH. There is a reduced compensatory insulin sensitivity, and the hepatic extraction of insulin is similar in NASH patients as compared to controls. Another study from Hepatology, which studied that the insulin resistance of confirmed 65% patient with NAFLD, had 98% of these patients had insulin resistance, and there was significantly high prevalence of insulin resistance as compared to those matched patient of hepatitis C etiology. This study, it also brings about the importance of exercise, not just for weight reduction or the improvement of parameter, but it also improves the insulin sensitivity, where in these patients, they didn't underwent significant weight reduction, but after 12 to 16 weeks of resistant training or aerobic exercise, what was found that the hepatic fat content significantly decreased in both these set of patients who underwent either aerobic or resistant training. And there was also a decrease in the fat percentage decline was up to 25 to 30%, and the fat reduction, the fat reduction in hepatic fat reduction, it in itself improved the insulin sensitivity. Then there is a role of systemic inflammation also, that the insulin or growth factor via the IGF-1 and phosphatidyl PI3K and AKT, it activates the mTOR pathway resulting in protein synthesis by inhibition of the FOXO. But with the systemic inflammation, there is increasing adipokines, there is decrease of the IGF-1 signaling, and increase of IL-6 and TNF-alpha, which actually start stimulating or activating the FOXO mechanism, leading to protein breakdown. This also brings us to another concept of metabolic flexibility or inflexibility. What is metabolic flexibility? It is the ability for preferentially using the appropriate fuel, that is carbohydrate, in the fed state, and in the fasting state, use of the free fatty acids or fatty acid. But in the state of flexible inflexibility, there is excess free fatty acid, and what has been proposed that it is the excess of free fatty acid and flexible metabolic inflexibility that lead to ectopic fat accumulation not only in liver but also in skeletal muscles, and this further increases the insulin resistance. This metabolic inflexibility was also studied in NASH cirrhosis patient, where patients, they were kept in a specialized chamber, and it was seen that those patients with NASH cirrhosis, the transition from the respiratory quotient of 0.7 was for the fatty acid metabolism, and one was taken for the carbohydrate metabolism. And it was seen that those patients who had non-NASH cirrhosis, the transition from fatty acid metabolism to the carbohydrate metabolism in the fed state was more even as compared to NASH cirrhosis patient, where the change of metabolism is either hampered or doesn't occur. And since there is an ectopic fat accumulation in muscle, we also have to understand the importance of adverse muscle composition, which is decrease in muscle mass, increase in fat-free muscle volume, as well as increase in the muscle fat infiltration or myosteatosis. And why this myosteatosis is important? Because it has been proven in previous studies that this is independently associated with survival. In this study, where the myosteatosis was estimated by CT scan, and out of 678 patients, 14% of these patients had NASH cirrhosis. Nearly 43% patient at baseline had sarcopenia, sarcopenic obesity in 20%, and myosteatosis was seen in 52%. It was seen that survival was significantly higher in those patients who didn't had any kind of muscle abnormality as compared to those who had either sarcopenia, sarcopenic obesity, myosteatosis, or all of the above. And it was also seen that this was significantly associated on multivariate. And for the progression of NAFLD to progression of fibrosis, it was seen that it is not just sarcopenia, but myosteatosis was also significantly associated, where 338 patients of biopsy-proven NAFLD, this was recently published in CGH in last month, where 29 months follow-up was seen, and the prevalence of severe myosteatosis was in 21% of patients with NAFLD, and 33% with NASH of any either mild NASH or severe NASH. And these patients of severe myosteatosis was higher in those patients who had higher grade of lobular inflammation or higher ballooning. Also, on follow-up, they found that when these patients had progression of fibrosis, that is from early stage of NAFLD to increasing stage, either in the form of increase in LSM by 2 kilopascal, or the overall cumulative, or the overall increase of the LSM more than equal to 7, it was seen that severe myosteatosis and HOMA-IR score were significantly associated with early NASH and fibrosis, as well as in the overall progression of NAFLD. This study was published in JHEP reports, where the adverse muscle composition was linked to poor functional performance as well as metabolic comorbidities in NAFLD. This was a protocolized, this was a UK Biobank imaging database of 9,545 patients. The adverse muscle composition was assessed based on MRI. The outcome measures were either functional performance, that is hand grip strength, walking pace, stair climbing, or frequent falls. And metabolic comorbidities that was studied was coronary heart disease or diabetic patients. It was seen that the prevalence of NAFLD in the overall subset of patients was 22%, out of which, out of the overall patient, 1.6% had sarcopenia, and in those patients, adverse muscle composition was seen in up to 14% of these patients. And what they found that adverse muscle composition, either both in the form of high muscle fat or decrease in the muscle mass, was nearly 3 to 4 times higher associated with both CAD as well as the development of diabetes. And also in the NAFLD subset patients with with adverse muscle composition, these patients had low grip strength, slow walking, and frequent fall. The same study group, they also assessed that adverse muscle composition is significantly associated with all-cause mortality in NAFLD. Another study from the UK Biobank imaging study of 5,069 patients and equal number of matched controls. Sarcopenia was assessed based on the MRI study, NAFLD based on PDFF of more than 5%, and what they study was all-cause mortality along with the liver fat, NAFLD, and muscle composition. They found that the all-cause mortality was in the whole cohort, that is 10,138 patients, was not associated with NAFLD or liver fat, but it was significantly associated with adverse muscle composition. And in the subset of patients who had NAFLD, it was seen that adverse muscle composition, high muscle fat infiltration, or low muscle volume, each of these were significantly associated with poor survival. So to summarize that the NAFLD and sarcopenia, there is an interplay. We don't know who came first, but otherwise we can say that the insulin resistance, vitamin D deficiency, chronic inflammation, myostatin, myokines, and physical inactivity all may have its role in the progression or development of sarcopenia or NAFLD. So what all treatment interventions do we have to offer? The dietary interventions that was being studied in detail was the first one that is published in the American Journal of Gastro. It was an RCT of 12 weeks with 32 patients. Indication was sarcopenia in cirrhosis patient, branch-chain amino acid with placebo, and they found that improvement in muscle mass was seen in significantly higher proportion of patients, 83% as compared to 46% who were on placebo arm, and there was also improvement in the liver fat index. This study from Nutrient 2019 and 21 was based on the was on the subset of patients. First one was for post-LT patient, where the hydroxymethyl butyrate was given along with placebo. They found that ASMI significantly increased. Another subset of patients where cirrhosis and sarcopenia was assessed, and they found that muscle function improved. This study from the Ann Arbor group, it is still recruiting, not published. The study design was RCT for 12 weeks. Indication was cirrhosis with sarcopenia. The intervention arm was behavioral, physical, and nutrition. It is interesting that the physical activity in these patients was based on an app-based number of steps, that is those patients who daily achieve more than 10,000 steps. Behavioral therapy is not weekly, but intervening counseling of the patients that to keep them motivated, and nutrition versus nutrition alone. And the primary outcome that they want to study is sarcopenia change on CT, the change in 6-minute walk test, and VO2 on physical activity. This study under Jaya ma'am, we are still recruiting where cirrhosis and branch-chain amino acid and the standard of care, and the effect of branch-chain amino acid would be studied on. We are studying on muscle mass, muscle quality, molecular markers of regeneration. Then the second intervention that we can offer for these patients is the exercise intervention. We have studied in detail that exercise it improves. The study from Roman et al. In 2014, RCT, 12-week study, where all these studies were on cirrhotic patients. They were not on NAFLD or NAFLD patients. The contraindication were marked symptomatic comorbidities. Intervention was supervised exercise, moderate exercise compared to control, along with leucine of 10 grams per day. Outcome measures were general health, which increased vitality and social function. Another study published in 2016, where supervised exercise was added with 30% calories on exercise days along with control. It was seen that intervention arm fared better as far as when the HVPG reduction was seen. This study from Borzicotti published in Hepatology 2017, where supervised gym exercise along with the diet reduction of 500 to 1000 kilocalories, they found that body mass decreased by 5 kg and there was a significant decrease of HVPG of 1.6 millimeter. And this study on a cohort patients, child A predominantly, 12-week study, home-based exercise with snacks and 13.5 grams of branched-chain amino acid. They found that the average daily steps was higher in intervention group. The muscle volume, leg and hand grip significantly improved. The recent RCT from our center, the closest that we have is the Shushruth study, where the addition of testosterone, that is for anabolic response, was studied with nutrition along with exercise. Therefore, I feel that this study targeted all the three mechanisms, the nutritional, exercise, as well as the anabolic response. An RCT of 102 patients, the primary objective was to see the increase in the appendicular lean mass index of more than 10% at 6 months, assessed on DEXA. And what he found that the higher proportion of patients, they achieved their primary endpoint in the next group, that is nutrition, exercise and testosterone group, 66%, as compared to 25% of the patients who were only on nutrition and exercise, not on testosterone group. And the mean fat mass reduction was significantly higher in the next group. No serious adverse events was noted in any of the patients who were on the testosterone arm. So to summarize that there is a close overlap between NAFLD and sarcopenia. The skeletal muscle, insulin resistance and inflammation, they are the mainstay of the pathogenic cascade, and the intervention has to impact all these pathways or the individual pathways which are affecting both the progression of liver disease as well as sarcopenia. And till then we have only the bitter pill to advise, that is exercise and nutrition pill, easy to prescribe but difficult to follow on our own. Thank you.